Ciao Vincent, good morning. Thank you for your kind invitation in my city, even if I've been working for the last time of my life in Udine. My presentation today will be very easy because I have to reset in a very easy way what you should do every day in your practice. With this slide, I'm sure I will make Jean-Louis Vincent happy because I'm sure that this one gas catheter is still considered the standard technique to measure cardiac output. So the top of the presentation should be the Swan-Ganz-Cat is still the standard technique to use cardiac output. Of course, I think everybody agree with it. But if we read in a different way what we have to do, for instance, in the hemodynamic optimization, we can understand that the most of the variables today can be calculated also without this Swan-Ganz catheter. The same if we want to be more physiologic for the oxygen consumption, or for we want to do something for oxygen delivery again, cardiac output, and so ahead, or for SCVO2, for instance, that we don't need any Swan-Ganz catheter. So this is true for all the kind of patients we treat in our ICU. Never mind if they are in a perioperative hemodynamic optimization or sepsis, trauma, and so ahead. So the question is, how can we do with or without Swan-Ganz catheter? Well, I think that we have to read again to the other side of the middle, not from the top to the bottom, but from the bottom to the top. So we have pressures, of course, we have volume today, then we have flow, and some doubts about the dynamic functional hemodynamics, because I think we have something just to understand better that what we do today. So this is a new way in which we should be able to do what we want to do and what we are familiar with in our ICU or our institution. And of course, we can't be without an echo machine, according to what you're doing, what kind of surgery or ICU you work. Well, the problem is that we usually keep the normal values of our parameters. And it's true, but never mind if they are cardiac output or SCVO2 or what you want. The question is, which is the top or the bottom? Do you want to begin from here or to the other side? So my position is that cardiac output is a strong history, and we can have more or less in the invasive technique, of course. But remember that the more invasive you are, the more accurate you are. Unfortunately, we have to treat the sickest patients in ICU. This is the standard of care, according to me. So we have really to understand what we can do. Well, just to be very easy, as I told before, I think that the first level is pressure. I have some concern about the dynamic functional hemodynamic because I show in few slides some doubts about it. So first, do you know which is there any consensus or any consensus on the tidal volume or the fluid, the total amount of fluid, the kind of fluid we have to use? The answer is no. Look at here in this slide. Hydroxide starch, gelatin, albumin, or look at the volume, 500 milliliter, 100 milliliter, body mass index, or tidal volume, 10, 8, 7, 10, 8, 5, and so ahead. Second question, how do you define a responder? Do you define a responder according to what? Cardiac index, stroke volume, cardiac output, or anything else? Or which is the target you find for a responder? Should be 5, 10, 15%. So it's difficult to understand how we have to move in this very, very delicate situation. And of course, there is no consensus about it. So why I'm so deep in this part? Because even if in a wonderful situation like they are, in which you are the best condition, the patient is totally paralyzed, you can control tidal volume, you can do what you want, even in this field, there are different, totally situation about the outcome. In this paper written by the Brazilian group, the outcome was better when you use systolic pressure variation. On the other side, this paper written by Samir Saka, if you do a good anesthesia, you had no different in terms of outcome, with or without dynamic functional indexes. So what we have to do about this kind of very interesting, because it's full of physiology inside, there is no indication of hypovolemia. If you have 15 of systolic pressure variation, stroke volume variation, it means that the heart works. Second, how can you define a responder? It's very difficult if the patient will respond, 50% of the patient will respond, it means only that the heart works, And at least we can say in the best condition, if you're in a hypotensive condition, heart rate very high, or no bleeding, if you are a normal variation, systolic pressure variation, stroke volume pressure forehead is normal, you can have a sudden heart failure. That's, very difficult to collocate in an ICU or in a critical patients. That's the reason why I will not talk about it, because I think we have to be easier, as I told you before. So the first step is all the patient has an A line and a CVP, of course. So this is the first step. Why we measure pressure? There is consensus about it. I think most of the authors agree with it. Also, this paper in which they destroyed the hemodynamic monitoring, they agree with the arterial pressure monitoring. The problem arrives with the second part of the first step, the central venous catheter. Well, preload is this. It's very easy to present preload with this picture. It's something that stretch like that. But preload is not a very easy thing like a reservoir. We put it and we can have a CVP or 4 or 12. It's not so easy because CVP is something more difficult, more complicated. This paper has been very well written, in which CVP is something like that, very small, in a big basket full of water or fluids, and the rules who give you this or that number are really complicated. So CVP is not so easy to be used, and every time I show this paper written by Jean-Louis Debulle in the first line, in which look at the numbers of responders and non-responders, very similar, and look at in the number of responders, there are patients who are able to respond to fluid challenge, even if the CVP is very high or the POP is high. But on the other side, the non-responder can have a very low CVP or a very low POP. So, is it useful for our patient? I don't think so. That's the reason why I think that we have not to guide fluid according to filling pressure. And the first level, as we published in this paper with Maurizio Cecconi and Christopher Hoeffer, we have to move from the first to the second to the third level according to very easy thing, easy to be repeated every day. So the first level, I will show you later, one per time. The first level, the second level, the third level should be always integrated if you have with an echo machine, of course. In which way, I will show you later. So this is the modern way to think the bottom and the top of hemodynamic monitoring. Let's begin from the first. As I told you before, the first step is A-line and CVP. And what you do a lot of normal ranges like that, and you have to consider what is normal range in your patient. This is the first step. I said again, don't forget SCVO2, because it's easy to be calculated. You can do continuously or not, it doesn't matter. It's important that you remember you can have it, and the importance is physiological rate. So you have several targets to follow in the first step. Of course, heart rate, mean arterial pressure, the urine lactate, CVP, with the question point, of course, and SCVO2. But if you need, I agree with Ezra Pereira, how many echo can you do in your ICU per day in a patient? If you are lucky 1, if you are really, really lucky 2, or if you're full of the very sick patient, nothing. So if you need, you can use the echo. But if all the parameters are normal, you don't need to use the echo. Or the normal range like that, normal pressure, normal rate, so no, you don't need it. But on the contrary, if the blood pressure goes down, the heart rate increases, or one of these parameters are not normal, you need to use the echo because you have to understand what is changing in your patient. So in this condition, you give fluid, doesn't change. What you do? This is the way in which you have to move to the second step. The second step, of course, you need to measure cardiac output. I don't want to show you why, because it's so easy to understand that we need. But how can we measure cardiac output? We can measure cardiac output when something doesn't work. And of course, today we don't need to use pulmonary artery catheter alone. You can use different techniques, Vigileo, Lidco, Pico, and so on. We have listened this morning, heard at least for 10 techniques. But remember, cardiac output can be integrated with something more. I don't strongly believe in stroke volume variation, pulse pressure variation, but I think you have to integrate it with SCVO2, of course, and with some volumetric parameters can represent the second level. Take care and remember, the more easy it is, the more repeatable should be the technique. So the uncalibrated technique are not so accurate. It depends on where you want to work, of course. Little pico, when you calibrate the system, they work. But on the contrary, this other technique can be dangerous in some condition. To be more precise, remember when the cardiac output is higher than 8, little and pico works. When you are in hyperdynamic condition, remember, not every technique is so accurate like the other. Or, for instance, like a Vigileo or like a Litco Rapid or like the Prem, when the cardiac output is higher than 8, look at the points of this Bland-Altman graph. They goes up, of course. So remember that you can use a lot of monitors to have a cardiac output, but remember that without the calibration, the accuracy decreases. So the uncalibrated techniques are very useful for what? For OR, for instance, which you don't do anything about cardiac output. On the contrary, when you have an hyperdynamic patient or a very sick patient in ICU, you need a calibrated technique. And just to be easy, as I told before, the second step is A-line, CVP, or central venous catheter, and a cardiac output technique you need. But remember, if you integrate this with a volumetric monitoring or the extravascular unwater, you have something more. ITBVE and GEDV is very similar to each other, so there is a lot of literature about it. And they give you the chances to create the front starting curve and just a paper to show how easy it is, how important it is to use in the first hours of your admission patient in ICU. If you construct an algorithm like extravascular water, GDV, and so ahead, look at the result in terms of using of norepinephrine. This is the lane of the patient with volumetric monitoring, without, like that. So more norepinephrine, more epinephrine, but it's more important the total amount of lactates. Look at in the first hours, the volumetric group are like that, pretty normal, and in the first hours, the lactates are high without volumetric monitoring. This is important. It's very similar to the reverse results, for instance. And remember extravascular unwater. Saka wrote this paper in a retrospective way, but the total amount of extravascular water is able to give you the mortality or not. The higher is the number, the higher is the incidence of mortality. And this paper that I show you, because it's a 2010 paper, again, yeah, it's the future. The extravascular water, according not to the body weight, but to the height of the patient, because the lung depends on the height, are similar results. The higher is the value, the higher is the mortality. So I think it's important to remember this target. So in the second step, you have more than one target. This is the target. These are the targets of the first step. These are the targets of the second step. You can integrate with volumetric or dynamics according to you, according to the condition of the patient. It depends on what you are familiar with. But if something still doesn't work, you need to evaluate with an echo how heart is working, and you can go directly to the third step. When there is a condition in which the pulmonary artery catheter is strongly indicated. First of all, for all the patients with the pulmonary artery pressure very high. In this condition, there is no doubt. You have to use it. But just to be more clear, I think that you have to use the pulmonary artery catheter in condition of pulmonary hypertension or with right ventricular dysfunction. And when there is a heart failure in which you need to integrate with the TE, of course, and then in the septic shock or in a liver transplantation patient. But what we need from S1 today is something more than pressure or cardiac output. For instance, the end-diastolic volume of the right ventricle, in which there is a correlation between it and left ventricular end-diastolic area. Look at the correlation here between the end-diastolic volume and the left ventricular end-diastolic area again, or as we wrote in this paper in liver transplanted patient, in which the correlation between the right ventricular end-diastolic volume and the stroke volume is higher than POP and CVP. So with this new advanced catheter, you can construct a logic regression like that, in which you can integrate the volume, the heart rate, and right ventricular ejection fraction. And with this, you can do this only with the pulmonary artery catheter, as Michael Pinsky wrote in this paper. So just to go to the conclusion of my presentation, we have three different steps with three different targets. You can go from the first to the second, from the second to the third, according to what you have, and according to the condition of the patient in which you are dealing with. And these are all the steps you can respect, but remember the time. Because if you wait a lot, there is no reason to go to the second, to the third step. You need to be very early. You can read this argument to the other side, but I think that everybody knows this here. But just 1 second, think about the opportunity to use this Swan-Ganz catheter here. We can have a CVO2 without Swan-Ganz catheter. We can have a cardiac out without Swan-Ganz catheter. The only thing we need to have monitor with Swan-Ganz catheter is the PLP. In this case, I think it's difficult to understand how and why we should use for all those patients as Swan-Ganz catheter. But I think it's important to remember that you can use all the techniques you want from the first, the second, the third level. It's important to remember that you have to integrate all the data you have. And remember that you have to create at your home the top or the bottom of your hemodynamic monitoring you have. Thank you for your